Thank you. I'm going to just introduce each of these three sessions so that you keep something in your mind, just 5 minutes. This is primary spine care. We talked about primary spine care, secondary spine care, tertiary spine care. This is primary spine care. This is in a village such as that in Shoshone, or a district, a small village anywhere in the country which has a clinic, or in a primary, if you're in Gaborone and you're taking care of patients in the primary care setting. What we do not want is for anybody in these settings to work as silos. This is one of those catchphrases around the world, where you have the chiropractor working by themselves, the physiotherapy working by themselves, the family doctor working by himself, and the traditional healer working by themselves, and the nurse practitioner working by themselves, and somewhere over there is a hospital, and if I don't like what I do, I just send them over there. That is not the model that we want to have. This is the graph I put up. There are certain cases which should be seen and managed in a primary spine care setting. So first of all, you integrate all the services. If there's a chiropractor and a physiotherapist, or a traditional healer, or a family doctor, or nurse practitioner, they coordinate their care. They study how to manage people with spinal disorders, and most people with class 1, class 2, class 3, in other words, people who have spine pain, but no other symptom, should be taken care of in a primary spine care setting. There'll be a few patients with severe chronic debilitating back pain who will have to be referred. A number of patients with early radiculopathy that's not severe, non-progressive, that's a 1A and 1C, 3A and 3C should be able to be taken care of. And some of the bony pathology that's not symptomatic and not dangerous should be able to be taken care of. The majority of people, 90% of all people who have a spine problem should be able to be taken care of in the community. We hope you'll get enough education and that we can create enough program so that we do not funnel all of these to a high-powered surgeon who has to spend 50% of their time trying to decide who needs surgery. We're looking at this community, the first row above, which is the primary spine care community in various parts of small communities, but they need support of the secondary spine care center. So every one of them should know which patients need to be referred on and which patients need to be referred to tertiary centers. This is an example. That's a little small writing. This is a real patient. Diego is a farmer who experiences some pain on a daily basis. He did not have any recent trauma, but had a traumatic fall when he was a teenager. His pain today is moderate, and it's interfering a little with his work. He previously contacted a village leader, a community nurse, who prescribed naproxen, but he did not get better. What I'm hoping you will learn in this next session is what are the options, what can you do to give this person some relief, and without referring them on to secondary or tertiary care. Back to Dr. Bridge.